is Jason Dixon. I've been doing insurance for about 27 years. To give you a quick background, started in the world of the carriers, HMO, back when HMOs were a thing. Some of the relationships, see Joe Denton in the room, he and I started working together 20 years ago. Been a long relationship. Then I went to the big consulting firm. I thought, oh, that's what I want to do is be a consultant because they seemed important. And then went to a smaller firm, helped them build a captive, and the last year and a half built Trinity Captive. So understand this space. My previous world at one of the consulting firms, a little company called Gallagher, had a company called Architect. And back in 2010, they didn't know really how to educate people on the medical stop loss captive. And even though I was a consultant at Gallagher, they couldn't even explain it to me, much less the employer, the end user. So for the last 12 years, that landscape has changed. And it's changed dramatically. 15 years ago in healthcare space, if you weren't doing disease management as an advisor, consultant, you were doing your clients a disservice. 10 years ago, disease management. If you're not doing some type of disease management, you're doing a disservice. Over the last 5 years, I call it the sexy term, what word's gonna get it? If you're not talking to your clients about a captive, you are doing them a disservice. So this session was supposed to be Captives 101. What is it? So, the easiest way to do a Captive 101 is to give you definitions, right? Dr. John, you ready for a test after this? Okay. Actually, well, the screen's here. I'm assuming you'll have your slides because there's a website. It's a great little website, Captive 101, for glossary and terms if you're really interested. That's a way to get familiarized with the captive. But at the end of the day, it's simply just a financial vehicle to pay for claims. That's all it is. Now, FMMA, cost containment strategies, is what you're doing inside the plan. But the captive, in and of itself, is the smallest piece of the puzzle. And also, when we get to some slides here later, if you think about it, you really don't want a captive distribution. It's just a double taxation if you're doing it appropriately. So, why are captives becoming more popular in the last 5 years? 56% of Americans can live paycheck to paycheck. $1,100 will put them in financial crisis. So employers, consultants keep offering employees a $2,000, $4,000, $6,000 deductible out of pocket. There's no way possible. Tom, you talk to employers.
Yes, sir.
What's their biggest challenge?
They want to contain costs and they want better quality health plan.
How do they do that? Those seem like competing.
At those two things. Yeah. The deductible can be lower with sound cost containment strategies. You can actually have health care provided at no cost and save money in the health plan.
So I did all the talking, so I just kind of jumped in. I got to kind of give an introduction. Can you tell a little bit about yourself and what you do?
Yeah, sure. I'm Todd Rogers with the Kipton Group, and I was asked to kind of pinch hit to jump in here when we had some scheduling logistics. And I think the value I can share today is we work with a lot of employers that want to adopt free market health plans, but we see many more employers that are trying to determine how it works for them, and we're also trying to determine if they're a fit for us. And so we talk to way more than we actually onboard as new clients for that reason. And one of the questions we get a lot is how can a captive risk strategy help us, or are we a candidate for it? And that's, I think, something that Jason's going to help us learn today. One thing I think that works hand in hand with the captive is that we're talking about the free market cost containment strategies, ways to improve the health plan and get better outcomes and actually lower the cost. That's what a captive wants. They want good free market, sound strategies for cost containment. And so I think Jason's going to take us through, the mechanics of how that can help you overall financially as an employer or advisor, anyone looking to work with.
So, if you are an employer and you believe that BUCA stands for Blue Cross United Cigna, if you believe they have your best interest, you wouldn't be at this conference, first. But if you're talking to employers that truly believe that, it's a head scratcher. You know, they want to complain about the rising cost of healthcare, but they don't want to make the change. And you're in this room because you've made that change. We're the disruptors, so it's hard speaking to the choir, so to speak. But when 56% of Americans are paycheck to paycheck, and the average household is $67,000, and they're still offering a $4,000 to $6,000 deductible / out of pocket, that's life changing. Thank you. Thank you. Yes. Hello. Thank you. Yeah, it's the live streaming. We're doing it for live streaming. Apparently, there's like 10,000 people online watching this right now. So this is a very important meeting. Now, when you talk to those HR folks, they go, "Well, Jason, that's great. You have all these tools and resources, but you don't understand our employees. They're different. Whether it's from a marketplace, whether it's from their demographics." And I'm just a dumb kid from Dallas. I have a DISD education, so I use pictures to tell a lot of stories. And I look at that HR person and go, "Well, how many of your employees lined up 3 hours at a big box retailer to save $300 on color television and then fight somebody over that?" And they kind of chuckle like you're doing right now. And I go, "Because we make it easy. If you want to save money at Christmas, what do? Shop Black Friday." It's real simple. Employees understand that. With $4 a gallon of gas, how many of your employees will drive 2 blocks for a $3 a gallon of gas? But when it comes to an MRI, and the doctor goes, "Nope, go right over there to that hospital, pay your $2,000 deductible for that MRI." Okay, a doctor told me to do it, right? Is that something you're seeing in Oklahoma with the employers you're looking at?
Yeah, I think employers are getting more in on the joke that the big health systems and the big carriers are doing nothing to contain cost. And through education and communication with your employees, really making a cultural change, you can not buy the $4 a gallon gas. You can move to better opportunities for that. It's hard because healthcare prices are not all transparent. We got some transparent providers in the room that are offering that opportunity, but the more education the employees get, the better opportunities they have to make better buying decisions.
So since this is the captive insurance 101, the difference between fully insured, self-funded, and captive, it's not real hard. Over here, fully insured. That means they're going to have a set premium. The employer pays that premium every month to the insurance company, whether they have claims or not. And the insurance company keeps the profit. Okay? Now, if they have higher claims than the premium, the insurance pays that. But guess what happens? There's a renewal every 12 months. And what's going to happen? They're going to get that 8, 12, 20% increase. Okay? Having conversations with employer groups all over the country, and they ask, "Well, I'm not sure about self-funding. It's scary. What happens if I have $1 million claim?" I go, "To me, it's more scary to be fully insured with Blue Cross because you have no control and they won't give you the data. At least when you're self-funded, you know what's going to happen and you have time to plan because you're seeing your data every month." So self-funded, all it does has your administration, your claims, and then you're going to pay reinsurance to a stop-loss carrier. Okay? For an example's sake, let's say we buy a deductible of $50,000. Okay? So that would be your stop-loss. And let's say you pay $1 premium. Once you pay $1 premium to that stop-loss carrier, you've transferred the risk from $50,000 and above. You have 0 chance of getting that dollar back. Make sense? Pay premium, transfer risk. All a captive does is take that same $50,000 deductible for the same $1 in premium. You put 60 cents in the captive and 40 cents into the reinsurance, and now you have a chance to get a portion of your 60 cents. Captive 101, it's done. You're all experts. Can you pass the test?
I'm good, but you're not wrong.
Do what?
I said I'm good, but you're wrong.
Which one?
Well, it's not $1 for reinsurance. It's not.
Well, that was an example.
And my
Hey, Dr. John, there's a lot of doctors here. They don't do good with numbers. I was keeping it simple, okay?
All right. So if my administration calls her.
But 60 and 40 doesn't equal $1. But you try to get a portion of your 60 cents back. That's all it does. In a graph, this is the fully insured premium. You pay the same premium every month, whether you have the claims or not. When you're in a captive, it's just self-funding. So what you do is you have admin, you have stop loss premium, and then the orange are claims. Your claims are going to fluctuate different every month. The insurance company is the green. They're hoping to keep your profit. Now, what a captive does, or you have to be, is self-funded. And that's where Todd and his organization as a TPA come in. We'll talk about being self-funded.
Yeah, so the TPA in its simplest form is the ability to help the buyers of healthcare purchase the healthcare, manage the health plan, and hopefully, a good TPA is going to help contain costs. So you're doing the customer service of helping the employees understand, and then you're bringing in all the claims management process, and then you're helping the employer have a better opportunity to buy and high quality providers. We've got one in the room here, Sean Kelly of Texas Medical Management in Austin and Houston, does a great job of transparent and bundled pricing. So that's the ability to make those good purchasing decisions. The incentive is to get employees to debt as much as possible, so you can actually waive any member responsibility when they go to those kind of high quality providers. So that's in a nutshell, what a TPA is able to do for self-funded employers is manage that compliance, help the consumerism, and keep all the trains running on time for a self-funded plan.
When you speak of captives, really, I told you in the last 5 years is when they've really become in vogue. When you look at stats, there's probably less than 5,000 employers that actually utilize a medical stop loss captive in the country. Less than 5,000. So the market share is wide open. So people are looking for it, okay? The average case size across all of those captives, the average employer case size is about 140 to 150 employees, okay? And 80 to 85% of the groups that are in a captive came from the fully insured market. Because the employer that's already self-funded with the captain is going, oh, we're doing all the right things. We don't need a captive, or we're too large. Well, we told you the captive is only the financial mechanism. What we focus on, using the same example, and we're going to use the same dollar premium, okay, Dr. John?
Sure.
Same $50,000 deductible. The employer is responsible. So that $1 million claim, the employer is going to pay from 0 to 50,000. Then the captive, where we put the 60 cents into, John, from 50 to 250, and then you bought reinsurance to cover 250 and above. So that employer that says, you know what, we're going to go bankrupt if we had that $1 million claim. No, you're not. You're only out $50,000.
Yeah, Jason, you mentioned that the average captive size is about 150 employees, and I think that's one thing we see with employers is a myth, is that employers think captives are only for the biggest of the big companies, but it could actually be most beneficial to a smaller group for the risk protection.
100%. I absolutely agree that small middle market account, 50 to 500, are the ones that are going to benefit from a captive the most. And there's some reasons for that, is because the reinsurance contracts, you're able to get no new lasers, you're able to get rate caps that they're not going to be able to get on their own. So the stop loss contract language is more beneficial. But also, when you have that $1 million claim and you're not pooled together with like-minded employers, you're on an island. And that reinsurance company has a couple options. They can either decline to quote you, not renew you, or they're going to put lasers in place. Okay? And so most captives, I don't want to say all because a new one pops up every day, but most captives, with their stop loss, they have to have a no new laser and a rate cap. Now, just like any other stop loss, you have what's called maximum claim liability, or an attachment factor. So before an employer signs that contract, they're going to know, what is my worst case scenario? And so right here, Every captive is going to show you this is your maximum liability. If your claims exceed that, the captive would pick it up for 20%, and then after that, the reinsurance. Okay? That's a lot. This is captive 101. We understand it? Now, one of the things, and actually to explain this slide, I'm going to go back. I mentioned earlier that the captive layer is almost like a tax. No one really wants to get a tax refund, do you? That just means you overpaid the government, they held on to your money, and then you get your money back. We focused, and while we're here at FMMA, and while they asked me to speak, we focused on cost containment strategies to drive down that first dollar coverage so those claims never hit the captive layer or never hit the stop loss carrier. And that's why being in a captive, your stop loss carrier is going to give you more advantageous contract language and more advantageous pricing so where they're more competitive. Okay? On average, we're saving our clients 15% first year, easy. This year alone, it's only year to date, it's still immature, we're running 60% of expected for our clients. A 230 life group in Macon, Georgia is on track to save over $1 million this year alone. And we've cut their employees' deductibles in half and things like that. That's the power of coming together with like-minded employers versus being stuck in the buka pool with people that don't care. When you're getting engaged, that's what a captive does. Okay? You're putting it with like-minded people that are here at FMMA. So one of the things Jay Kemp and I are talking about, how do we get more employer groups here? Because that's where the holdup is. Yes, no offense, brokers in the room. You're in this room, so you're not part of it. But I talk to brokers every day all over the country. And let's be honest, most of them are lazy and dumb. And they just want to hit the easy button and renew with Buka. Now, I said over the last 5 years, captives have become important. So your broker has gotten smart. I don't want to lose my business, so I'm going to get a captive quote, put it on a spreadsheet, so when that client goes, hey, you never showed us this, now they go, we showed it to you. Remember last year we looked at those? It just wasn't a good fit for you. Because the broker had to do a little bit more work. Maybe make even less money because now it's transparent and they didn't want to show that they were making a 5% commission with a $5 override. Okay. All right.
It doesn't show up on the spreadsheet either.
It doesn't show up on the spreadsheet.
It doesn't show up.
Oh, show up. Yes, exactly. When you're putting a captive next to a fully insured, because and this goes, you're Joe Denton, right?
I am.
Okay. You sold a few of these.
I have.
On a spreadsheet, that CFO wants to look at what's my maximum exposure. And I tell them, if you're worried about maximum exposure, I don't want you in my captive. Because you lied to me in your RFP. Because you gave me your claims and said, this is what we expect your claims to be. But now you're focusing on the maximum. If you have those claims with Blue Cross, what's going to happen? You're going to get a 30, 40% increase, right? And you're worried about a 10% higher cost. But you're exactly right. On a spreadsheet, it doesn't show well. Does the gifting group get spreadsheeted when you're doing the stop loss with employers?
Yeah, absolutely, and it doesn't tell the whole story.
It's frustrating because, like I said, employers complain about their top 3 line item expense, which is healthcare. It's usually employees' number 1 frustration. But when you give them a solution, they're like, not this year. Blue Cross gave us a 6% increase for this morning.
Right.
We don't want to disrupt our employees. Okay? And actually, if they would do it, you're actually giving them better benefits in most cases. Now, one of the other things, we talked about taxation and captives, right? And we said it's like a tax. You don't want to really get a tax refund. But one of the things that if you are looking at multiple captives, you want to look to see if they're reciprocal or not. If not, you're overpaying 21% in taxes. And most of them, because the IRS constitute every insurance company as a de facto C Corp, when there's a profit in that captive, they have to pay a 21% income. And then when they actually get the distribution, those clients that receive the distribution have to pay long-term capital gains tax. If you build it as a reciprocal, now It's allocated to the members. Think of USAA. Everybody see the commercials? They're a recipient. It eliminates that 21% tax. So now the distribution back to your clients is a bigger number from that profit on the captive. So if you're looking at captives, I will say this, there are great captives. People always tell me, because as a matter of fact, David was with a company called True Captive. And they were like, are you sure you're our competitors? Do you want to sit on the same stage with David? And I'm like, absolutely. There's less than 5,000 employers in the captive. This isn't secret sauce what we're doing here, okay? It's still insurance. And most captives that I know of have the cost containment strategies. And that's why we're here. And that's where the transparent bundle pricing and all the things that Dr. Keith Smith has brought to the forefront. And I'm thankful for FMMA because a lot of things that have helped our clients through the cost containment strategies were found out here at this conference. So thank you for that. Any questions on the overall captive? Before we get into Trinity, you want to talk about Kipton and Kevin?
Yeah, I had a question for you. I mean, you went through some really amazing cost savings for some clients, and I think you said first year on some, but isn't it in the majority of cases, folks that are, especially maybe coming from fully insured, that think they can flip a switch and get in a captive, and you're going to have this dramatic savings. They might be disappointed. It's much more a long-term horizon view to be able to contain your cost over time.
Yes and no. I mean, we're seeing on average about a 15% immediate savings. So it's not huge. Where the real savings comes in, we call it the water cooler effect. And I know Joe has put numerous clients with us, and he's seen it. So like when we send someone to Dr. Keith Smith Surgery Center, right? When we're trying to explain that to an employee, we have two heads. And they think we're going to pick them up, and they're going to some back alley metal building. With our clients, we actually pick them up in a limousine, put them on a first-class airplane ticket. When they get there, we pick them up in another limousine. In Oklahoma City, it's the Skirvin, right? It's one of the nicer hotels in downtown.
Yes.
In Naples, Florida, it's the Ritz-Carlton. We want this to be an experience for the employees. Waive deductibles, waive co-insurance. Give them $1,000. When the employee goes up to their bedroom, the hotel room, there's a custom gift basket waiting on the bed. We're giving them $100 per diem per day. So now let's go back to those stats. 56% of Americans live paycheck to paycheck, and you're offering your employees a $6,000 out of pocket, and the surgeon's charging $35,000 for a knee surgery. What does Joe Lunchbox do? He's life-changing. And here's what Joe Lunchbox does. He comes into work on Monday morning, slips and falls, now it's a workers' comp claim, and your bond factor just went up. So this is a double whammy when you start talking about cost containment, because when we're able to offer free surgeries, that changes not only the workers' comp, it also helps in employee benefits and the overall morale. So,
Jason, tell them about the reprice that United Healthcare had the knee replacement on the same person. It was $100.
well, see, Joe used to be one of the bad brokers. And his client was with United Healthcare. They had hip replacement and knee surgery.
Same person.
Same person, $114,793. You can go right now to Oklahoma Surgery Center, and I want to say it's $15,099 and $9,760. So, is that pretty close?
It's pretty close.
Pretty darn close, right? So we could put them in a Skirvin for 3 days. Give them $1,000 instead of that first class. Let's just double some of the costs and say we did it for $40,000. That employer just saved $75,000 had that employee chosen that. So that's why we incentivize them with the first class airplane tickets, the nice hotel, the $1,000, the $100 for the gift baskets and all. Okay? So, the last half they told us, talk about Trinity. What does Trinity do? Basically, all a captive is organizations that are frustrated. They're tired of that hamster wheel. Going, you know what? There has to be a better way. And like-minded employers come together that all can create efficiencies, share best practices, i.e. cost containment strategies, what you're here to learn about, and at the end of the day, return to profits. So what makes us unique? We cut deductibles in half. It's not rocket science really either. Broker. How many open enrollment meetings do you do?
All of them.
All of them? Do you think you're good at it? So it's their employer's top 3 line item expense. You get 45 minutes to an hour to do it, right? Maybe it's mandatory, maybe it's not. And you sit there and talk, you got a $500 deductible, 20% co-insurance right? And everybody falls asleep except 2 people. Those 2 people don't get sick for 6 months. They have no clue what you said. But when Trinity comes in and we go, what we're going to do is we're going to cut your deductible in half. They're like, okay, now let's talk. That's different. Because every other year you've come in and you've raised deductibles, raised co-pays, raised the cost. So one, we want to garnish their attention. The other reason we do it is because we have no disruption. I don't care where your clients are or what network they're in. I can look at you right here, right now and say there's 0 disruption if your employee comes to Trinity Capital. Because HR's number 1 hesitation, don't change and mess with my employees. Okay? So we're trying to eliminate those hurdles. So we've done that. So don't have to change providers, don't have to change facilities, don't have to change RX. We provide the free surgeries, free imaging, free telemedicine, free physical therapy, and some free specialty medication. So we're now providing employees a richer benefit, saving the employers 15%. So when I built Trinity Captive, I had one thing in mind. It was member satisfaction. Okay? It wasn't saving money. Insurance is still expensive. When we're saving 15%, they're still spending billions of dollars. Okay? But the clients say, you know what? We know we're going to spend this money. We have to have benefits to attract and retain employees. But it's a miserable experience. When they call customer service at Blue Cross or United, they get in that phone tree, they get bounced around 3 different times, and then they need to call back next week and they're talking to somebody else. We created Trinity. And all a Captive does, or how it's built, is just like every other insurance company on the face of the planet. You gotta have stop loss, you gotta have pharmacy, you gotta have a network of providers, or RBP, which that would be your network, and then you have to have somebody to pay the claims. So, who does Trinity Captive use? We are very fortunate. Web TPA is the largest independent TPA in the country. Do fantastic. I know we have 2 great ones here. Are there any other TPAs in the room? Because Boone Chapman's here. You're a TPA? Who are you with? I'll give you a shout.
It's PPC TPA.
Oh, PPTCPH, you got a shout out. There's 10,000 people watching. I'm trying to give you free advertising. And then Todd is with the Kempton Group. Okay? So you have to have somebody to pay the claims. You got to have a network. We give our clients options. You've got to have stop loss. So someone's going to have to reinsurance those large claims. We actually have 2 that we run simultaneously. And then we call it, is anybody here a PBM?
Overnight.
Who are you with?
Disclose our items.
Disclose our name. So a gentleman in the room once told me he's never met a PBM that couldn't save him money. PBM stands for perfect business model because those are the real liars in the room. Okay? I'm teasing you. Okay? We still friends? But we actually don't believe that they manage much, right? So we call it a pharmacy benefit optimization. It's just a fun. But I will tell you, one of the things that we're able to do is drive down costs with an open formulary. So we talked about no disruption. Those savings, we're not coming in and drilling down. When we say member satisfaction, we don't want disruption. So we don't want the employees, when they go to the pharmacy, to go, oh, no, well, new formulary, that's not covered anymore. So we open it up for the first 6 months so we can get the data and understand what we can do. Now the employer has education of what screws do we need to turn to create the savings and how can we create less friction. Now, there's a lot of concierge services out there, and they're great. You might have heard of Healthcare Blue Book, Compass, Quantum, but those are third-party entities. When we built Trinity, we wanted to have an internal employee. So this is a co-employee of not only Trinity, but also Web TPA. So they are in the system when your clients would call in and talk to them. So they don't have to hang up the phone and go, hey, we got to call Meritain or we got to call Kempton or something. Our navigator is in the system. Free market medical, what are the cost containment strategies? They're endless. And one of the speakers that was talking about the worksite, and I get calls all the time. Let us help you find ways to create more savings. They are coming out. The things that are going on in the marketplace are unbelievable. But these are the things that we focus on. You want to talk about some of the cost containment strategies inside of Kempton and what you are doing? Because I know you have a bolt-on and so forth.
Yeah, well, specifically on the bolt-on, that's a plan where a customer, client can access direct contracting, being able to access the bundles out there from any existing TPA or any existing carrier. So we're able to put a separate engagement. It's kind of a mini TPA engagement where we direct those members into the free market, providers to be able to have those bundled procedures, which is going to be no out of pocket to the member and save the plan money, going to be that concierge approach on that. We even do little EOBs, EOBs for all of that. So that's an engagement where any carrier can kind of get into the shallow end of the water, so to speak, on free market healthcare just by a bolt-on program.
So one of the things, educating employees, how do we do it? Obviously have a different philosophy when it comes to open enrollment, but we want to make it simple. So they're going to get a plastic card, just like every other insurance company they've ever had their entire life. You want to spend money, you've cut your deductible in half, reduced your co-pays. If you want to spend money, pull your plastic card out, use it like you've always used it. If you want it for free, you simply call the patient navigator and all of these services are free. We make it real simple for them. It's not complex. I was actually on a call yesterday. We were doing a client 6-month review. They actually wanted to do a second open enrollment meeting. So it was an all hands on deck employee. Because they understand it, employees understand it, but they're like, literally yesterday on this call, this gentleman said, hey, can I send you my EOB? My daughter went and had an x-ray this morning and we paid $147 for this x-ray. Will you make sure it's right? And I said, absolutely, send us the EOB, we'll take a look at it. But had you simply called the patient navigator, that x-ray would have been free. And you would get, oh, that's right. So those are the type things, it's gonna take time, education, but the more you get it, they'll get it. So why does this work? The patient, they're gonna receive better outcomes without the financial hassle. The providers, they don't have to worry about prior authorization, working with insurance companies, and in most cases, is it fair to say they double? Or at least more? And then the plan. When the plan, the employer, every time an employee utilizes one of those benefits, the plan is going to save 30 to 50%. So, for Trinity Captive, why would someone want to become a member? From a member, from the employee, it's a better satisfaction. We've cut their deductibles, we're offering them free benefits. The biggest negative we get is, this is too good to be true. How are you doing this? There's no disruption, so we've eliminated that hurdle with that HR. And then there's better benefits. From an employer standpoint, why would they want to become a member? Cash flow and profits, innovation and creativity, and then flexible and transparency through the openness. We hit our, any questions? Because we want this to be interactive.
Yes, Oklahoma Surgery Center is without question gold standard in pricing. We use them constantly. It's unreal. But I'm in Georgia. I grew up in Macon, so you're doing there. So we got medical orthopedics there. We got Ortho Georgia there. So how effective is Trinity in lining up these prices? Obviously, we're using their pricing service, Atlas. So how effective are you guys being in? I'm having trouble. I negotiate all the time, so it's especially in orthopedic.
So there's some folks here at this conference, and I'll let, do you want to answer it first, and then I'll answer it? Or do you want me to take it?
Go ahead. How to get in new markets?
Yeah, get in new markets. So there's some vendors here today. Savos, they're actually in the room, Coral. They're going to help you. There's some others. The way I met Dr. Keith Smith and Darla actually in the Grand Cayman Islands back in 2014. My wife and I went on a boat trip with them. We're like, what do you do? How do you do this? And that's how the relationship. So he was the only one we were using. And then through FMMA, we found out there's other people that do this thing. And if you know Dr. Smith, he's promoting it, right? So he's at Wellbridge, exactly. Bridge Health used to be one of the ones that was doing it, but then your relationship started growing.
I'd love to team with you in the Georgia area.
Do what?
I said, I'd love to team with you in the Georgia area.
Let's talk after this. We've had very good success in Georgia. Very good success.
And I'd add that, sometimes you have to really make hard choices in terms of redirecting folks from Georgia. The plan could pay for travel to other places. Facilities are going to have a great experience. And once the physicians in your market start seeing changes like that, losing cases, they may be more adept for change. We at the Kempton Group have gone into, markets that we haven't traditionally focused on, mainly because, folks from this conference have identified we want to do free market solutions in these areas. And, there's layers of difficulty, and you're getting in with maybe 1, 2, 3 providers initially, and you're just trying to grow the movement and educate. Bring those providers to FMMA.
Indeed.
Yeah, word of mouth referral. Denise is on her phone, so I'm going to pick on her. Denise works with another TPA, and would get a call and go, hey, will you vet this facility, ambulatory surgery center? These doctors, could you get them contracted? And she'd hate me, but we'd have to go down and visit and do all the work. And 90 days, 6 months, we'd have it wrapped up, have them in, and now you have a direct contract. Yes, sir, back.
Yeah, on the 100% benefit card that you showed on the screen, I noticed the email address is Healthcare Highways. Explain the relationship there and the dynamics,
Yeah.
what's involved.
So I've had a relationship with Healthcare Highways. Chris Wilson and myself, we've known each other for 25 years.
Sorry.
No doubt. Whoever said that. So. If you know the relationship between Healthcare Highways and Web TPA only works with groups 2,000 lives and above, unless Trinity captive. And we were able to get through that through the Healthcare Highways.
I'm just curious because a lot of their contract language is avoiding direct employers.
We don't use their network, only in Oklahoma, where they have
the
that.
network avoids.
Through Kempton.
Yeah, their network kind of avoids direct contracting, or it's
We're not using their network.
okay.
We're only using their TPA services through the Web TPA portal. It's a unique relationship.
Jason,
Yes, sir.
I don't see direct primary care on any of your cost containment methods.
And we're not opposed to it. We can plug and play it into it. We just haven't put it in as a mandatory benefit.
Okay. The other question is your list of solutions from Web TPA down. Is that a set firm list of solutions?
Yep.
Or can other partners, we look at other partners? Connect Benefits here at the conference. They're a care coordination provider that does an amazing job. Tracy Kreger, I don't know if you know. Tracy is, if I could use Tracy Kreger in that model, this would be a vastly more appealing.
When you say care coordination, not a TPA,
No,
not a stop loss,
uh-uh,
not a BBM,
uh-uh,
not a network.
nope.
Nurse navigation.
No, care navigation, care coordination.
They're not part of the four. The four are bundled.
Okay,
We have to use Web TPA
okay.
because to do all the things that we do, and that's the problem. And they're, like I said, other captives are great, but when you're using 5 different TPAs,
It can be crazy.
they're not going to administer it the same way, right? We want to train and get those to administer a certain way. So some of our things are, so that's called a bundled approach.
Right.
A la carte, there's other captives, and those are just philosophical differences. One's not right, one's not wrong.
Sure.
They're just different.
Last question. You say no disruption, but you use reference-based pricing.
Only on out of network. We do
Okay.
not. We use full PPO.
What happens when they get a balanced bill? Do you not consider that disruption?
Well, because no, you go one step further. We're saving them so much money. There's so much waste. You're here because there's so much waste in healthcare.
What happens when they get a balanced bill in the network? That happens all the time.
No, but with us, I'm gonna finish now. We tell our employees, when you get that balanced bill, send it to the navigator. We pay it 100%. We pay bill charges. That's how dumb these doctors. If you really want to know the biggest hurdle that we have is when someone sees Trinity Captive or a Pareto or a Himpton Group, and it's not in their market, they're so trained to look at Blue Cross, United, Cigna, or Aetna. And when they come into the doctor and hand them that ID card, oh, we don't take that. We're not in that network. Or when you have the Aetna network and you go, well, that's good. Now they understand that. Nope, they log into Aetna. This is being recorded, oh well. The two rudest people in the world are church gatekeepers, church secretaries, and the insurance person at doctor's office. If you can help me how to figure out the insurance person at a doctor's office, that's our biggest problem from a communication to an employee. Because when they hand them that card, they're like, sorry, no, pay cash, see you next week. Because they don't take the time. And if you look at our ID card, we make it really simple. If you have any questions, call the patient navigator. It's right here. They'll explain it all to you. And oh, by the way, to answer your question, we're going to pay that doctor bill charges. So charge us $200 for an office visit. Okay? Because we're saving $30,000 on a surgery. How many office visits are you going to have? So we'll pay bill charges all day long. So that's the no disruption. But to get to that balance bill, and it was out of network, RVP is on the back end of it, usually is customary. But once the employee gets that balance bill, we pay it. Yes, sir.
So you talked about the kind of water cooler method, and obviously you got care coordinators, but what do you do, what do you see for veteran hospitals to increase utilization within the employee here to know about, so they don't forget to call them out?
So we do a couple of things. We start working with their safety managers, because everybody has a safety meeting once a month or whatever. We go, just give us 5 minutes at the end of that, once a month. We have a communication hitting on certain topics each month that we send out and communicate that through the HR. But one of the things that we do, like if someone's going for that surgery, whether it's local or they have to travel, if this is the first time for an employer, can't require it, but we highly recommend the HR goes with them. Because what's going to happen, Dr. John needs surgery 3 months later, and he's going to walk into HR and go, hey, was that thing for real? Was it real? And if they've never experienced, the HR's like, I don't know. The owner made us put this plan in place. They say it works, but I don't know. But when that HR is actually there and sees Dr. Smith's facility, and they're staying at the Skirvin Hotel, and yes, they did pick us up in a limousine, and the bedside manners, they're like, oh, it was unbelievable. So that's how
one of my questions was, how do you prevent that surgery from ever, or imaging going to the hospital? Meaning, are you pulling codes, or are you pulling, if they're referred to an ortho specialist, do you immediately call them?
So
this looks like you're on a path to a really expensive.
So if it's coded, we have the navigator reaching out to the employee going, John, you just called in for an MRI on your right knee. You need surgery? If you do, remember, we've cut your deductible in half, so it's $2,000 down to $1,000. That's all if you use your plastic card. Or we have care navigation. We can send you to one of our 3,000 facilities across the country.
I got a question.
Yes, sir.
Did you say you don't pre-cert or do any pre-certs?
No, we do.
You do, okay.
From a doctor standpoint, we don't. So if someone comes through the navigator, and our navigator, Louisa, calls Alice, Dr. Smith said, hey, we want surgery on Friday. Dr. Smith doesn't have to go through pre-surgery. If Dr. Smith says we need surgery, we're having surgery.
But if it's outside that.
If that's outside that, if it's in the normal Aetna network, yes, we have to. It's part of the
you
contract.
redirect from those pre-certs?
Huh?
You actively redirect?
Yeah, so when that's just what he was asking. So when that pre-cert comes in, the navigator red flags and says, hey, John, you just pre-certed for this surgery. You know you can do it at Baylor Scott and White for $35,000, or you can do it at Oklahoma Surgery Center or Legion or one of the other ones for free. Not only free, we'll pay you $1,000. Your choice. Any other? Yes, sir.
So when we talked about the 4 elements that you need, the network being one of them, do you qualify from a cost containment standpoint? Does Trinity vet and qualify, I'll say, new network potential participants, or does it start at the web TPA and rely on them to present those, is it the,
Web TPA has zero input on our networks. As far as discounts. Now, they have to have contracts because they're our TPA, so they had to have contracts or we help them get contracts.
but that's
From an actuarial standpoint and the calculation, we're working with our network team and the stop loss carriers as well.
but so Web TPA is, I'll call it the choke point as far as outside organizations working with you guys. Everybody has to be with Web TPA. Correct. Got it.
Or direct through the employer. If it's going through the claim function, yes, but if they want to do it direct. Any other questions?
What's the minimum sub?
Minimum for Trinity or in just general captives? Trinity, so 25 is technically the minimum. When you look at all of the tools and services that we put in there, i.e. a web TPA, it's expensive. You get under 75 lives, it gets challenging to make those finances work. Now, we have a 50 life group, we have a 35 life group, we have 2 65 life groups, but then we have a couple hundred groups. So the average case size, you get over 75, that's where it really makes sense. Other thing, like with Aetna has a minimum of 100. So if you want the Aetna network for the logo, you're gonna have 100 plus.
Start hiring.
Or what?
Start hiring.
Start hiring.
Hiring.
Yeah.
If an employee gets into the stop loss layer, do you ever get any pushback from the stop loss carrier on the first class airfare, on the hotel stay, even though they say you're saving money overall, or is that written into the stop loss?
Oh, no, it's written into, they love it. They want that. Because, and here's the other thing. Remember, the stop loss doesn't hit until 250. So they're not in it. They're more worried to where a stop loss would be is on the aggregate side, the left to right, that maximum claim. So if you had a large claim and then we were, but no, they see the numbers, they'll gladly do that. I will say some of the employers push back. They're like, don't do it on the phone. And it's really a black car service, but we want it professional because it's an experience. Some of these people have never stayed in a 4-star hotel. Any other questions? I think we're over time because Dr. Smith's back there saying, wrap it up. We thank you, Dr. Smith, for asking us. Todd, thank you for jumping in. Literally Wednesday morning at 1 a.m. we get an email going, David's out. Can you welcome to the program? So thanks for doing it. So, everyone, thanks for coming. Good luck the rest of the week.